Let's start Chapter 9 now. In the DSM, it's titled Somatic Symptom and Related Disorders. We should know this term for this category. You'll see featured is the word somatic, and let's focus on that for a moment. Think back to intro psych. Perhaps you learned the term soma. If you did, it would have been discussed in the topic of the neuron. Take a moment and see if you have any associations for the word soma. And it's okay if you don't. Did you come up with anything? If you did, you might have noted that soma refers to body. For example, in the neuron, the soma would be the body of the neuron, but in general, soma means neuron. So in the context of our current chapter, it refers to conditions in which there are body symptoms, but no organic, no real underlying issues. Now, 3 are discussed in the DSM, and we'll discuss all 3 today: conversion disorder, somatic symptom disorder, and illness anxiety disorder. Now, 2 of the ones that are not somatic symptom disorders will also be discussed. They are traditionally discussed in this chapter in virtually all abnormal psych textbooks, including yours. These will be the psychophysiological disorders and one called fictitious disorder. Let's start our exploration of somatic symptom and related disorders with conversion disorder. Now, conversion disorder is an older term, but it's still recognized by the DSM. The preferred term is much more complicated. That would be functional neurological symptom disorder. That would not appear on the test, the new name, unless it was a bonus. Now we'll start our view of conversion disorder with a brief glimpse at its history. It is typically associated with the patient by the name of Anna O. Her real name is Bertha Pappenheim, and no, you don't need to know that. It's generally thought by many students that she was treated by Freud, since he based his psychoanalytic theory on her case study. But in fact, she was not treated or seen by Freud. She was treated by one of Freud's colleagues, Joseph Breuer, initially with hypnosis and later the talking cure. But still, as I mentioned, her case study profoundly influenced Freud and became the basis of his psychoanalytic theory and thought. Now, interestingly, even though Freud labeled the therapy a great therapeutic success, it was so unsuccessful that Breuer just threw up his hands, gave up, and had her transferred to another institution. Now, Anna O, as we'll call her, had a very, very negative view of Breuer and psychoanalysis. Now, she went on to be a very accomplished woman. She was president of an organization that had 50,000 plus members, the Jewish Women League of, the League of Jewish Women, and she was active in social work and always a strong opponent of psychoanalysis. If you should like to learn more about her, I did include a link that you might enjoy reading. But again, it's optional. Let's continue our look at functional neurological symptom disorder. The key shared feature with all the other somatic symptom and related disorders would be that there's no underlying medical condition. There's no organic cause. The symptoms are therefore psychological. Now, in this particular one, the symptoms fall in the category of either sensory or motor. The person has sensory abnormalities or motor abnormalities without an underlying basis. There will typically be significant distress or impairment, But though sometimes the person will show bell of indifference. And we'll touch more on that momentarily. So it's noted the symptoms are sensory or motor. Sensory might be blindness. Maybe you've heard the term hysterical blindness or hysterical paralysis. So the person claims blindness and they believe themselves to be blind, or they're unable to produce a voice, or they can't feel part of their body. Your textbook shows a picture of glove anesthesia. Or they might have motor symptoms such as tics of the face or body, swallowing difficulty, walking issues, or seizure-like issues. And you might say, seizure-like? Well, the person during the seizure event, their eyelids cannot be opened because at some level they're keeping their eyelids shut, and they remain conscious, which would be highly, highly, highly atypical for a real seizure. Now, how do we tell conversion disorder from a true physiological condition? A number of factors should be present. For example, a medical explanation cannot be found. But that's true of many conditions that are indeed medically caused, so you'd want more than that. Now imagine you woke up blind or paralyzed. Wouldn't you be extremely upset? Wouldn't you want the ambulance? Wouldn't you want to go to the hospital immediately? That would be typical, but some patients show what's called the bell of indifference, a casual attitude. Well, isn't that unusual? If I don't get better, I should see a doctor later today. So the attitude doesn't fit the gravity of the event. Also, there's often benefits to the person. They get a lot of attention, or maybe they get out of things that they find very scary. Maybe a pilot who has blurred vision on the day of their first flight doesn't have to fly. A surgeon on their first day of real surgery who has a hand tremor can't do surgery. So it will get them out of some event that they maybe find daunting. But again, remember that these are not faked condition. The person truly believes that they have the condition. One last feature is that there's typical medical inconsistencies. The person's paralyzed, but their legs move while they sleep. They're blind, but if something passes in front of the face, they'll blink, and so on. So we'd want most of those conditions to be present, or at least some of them, before we dare to go on and diagnose conversion disorder. Even then, there is the danger of misdiagnosis, and sometimes years down the road or months down the road, the person will be diagnosed with a true physiological condition, such as lupus or other things. Let's next consider a couple explanations. Let's continue our exploration of the category somatic symptom and related disorders by looking at the one that is most obviously referred to in its name, somatic symptom disorder itself. A person on this will have numerous symptoms, but again, no organic basis will be found. The two complete categories are somatic, in other words, all sorts of body pains, from maybe headaches to muscle aches to bone aches to itchy skin to whatever, or just general pain, probably multiple areas. They have a significant distress or impairment. Indeed, the illness often becomes the focus of their life. They spend excessive time worrying, they gather information, they read a lot, they maybe journal, they're visiting doctors, rejecting doctors, getting new doctors, maybe throwing a full body scan. If you're a friend, don't ask them about their health, because you'll hear a lot about their health. So again, it takes over the life often and becomes the central theme. These individuals are particularly heavy users of medical services. And remember, as with all true somatic symptom disorders, the symptoms are not fake. The person legitimately believes they are ill. When they seek medical advice, they are not relieved by negative symptoms. They just typically assume the test didn't find it, and they will continue their medical journey because, again, that assurance that they indeed are ill. So thus far in our discussion of somatic symptom and related disorders, we focus on conversion disorder and we focus on somatic symptom disorder itself. But let's focus on the third and last illness anxiety disorder. This person is convinced that they have an undetected illness, and they're typically focused on a specific illness. Cancer, HIV, lupus, could be really any disease. So they're convinced they have it. And what would you do if you were convinced you had an illness? You'd probably go see the doctor. Are you relieved at the negative test results? No, the test results you're convinced didn't find it. So you'll do more tests and maybe more doctors and start paying out of your pocket. So like the other disorders in this category, causes significant distress or impairment to the individual. Now, it's somewhat similar to somatic symptom disorder, with some exceptions, of course. So with this disorder, the focus typically on a specific illness, and unlike somatic symptom disorder, they'll have no or very few symptoms. So with the somatic symptom disorder, typically lots and lots and lots of symptoms. With this disorder, few or none. Let's briefly consider some of the many, many different treatment options for the somatic related disorders. Psychological therapies include CBT, mindfulness, and dialectical therapy. You probably remember that cognitive behavior therapy and traditional behavior therapy focus on changing people's behaviors, especially tied to cognitions, illogical thinking, harmful thinking, negativistic thinking, all or none thinking, and so on. Other options, forms of CBT, include mindfulness, in which the person is taught to be more attentive to the moment, the thoughts, the feelings, and the behaviors, because awareness leads to understanding, and with understanding, they can be more readily changed. Techniques used in mindfulness would include such things as body scan, meditation, and actual mindfulness exercises. A particularly useful therapy is dialectical therapy. This one is focused on having people to be more in tune with their emotions and to learn how to control their emotions. And since emotions can always be changed, to accept distress and find that it is not a devastating event. Biological treatments often include antidepressants, which, as we know, are not just limited to the use of depression, and dramatically increasing physical activity, preferably to at least 4 to 5 days a week of at least 30 to 45 minutes, can often have a significant positive impact on these disorders. So we noted on the last slide that fictitious disorder is a somatic symptom and related disorder. We know that malingering is not. Let's consider another disorder which is not in our particular chapter category, at least the DSM category. That would be psychophysiological disorders. They used to be called psychosomatic illnesses, now psychophysiological. These are disorders that are either caused or exacerbated by stress. Again, not a DSM category. If you will, take a moment and think of disorders that you think would fit this particular category. In no particular order, some forms of headaches as well as backaches and other muscle pains, insomnia, asthma, ulcers, though they often need to be treated bacterially as well, I should add, and hypertension, in other words, high blood pressure, and cardiovascular disease. So these can either be caused or, depending on the disorder, worsened by stressors. Let's now consider, in our discussion of the somatic symptom and related disorders, fictitious disorder. The other two disorders we'll talk about in the remaining part of this chapter are not considered to be a somatic symptom and related disorder. So, fictitious disorder. In this one, the person is creating or inducing symptoms for psychological reasons. So they're actually creating the symptoms. The forms are imposed on self or imposed on another, which is known in the vernacular as Munchausen's. Please note that it's factitious disorder like the word fact, not fictitious disorder like the word fiction. So, for example, causing a rash on oneself, causing repeated infections on oneself. Unfortunately, another, such as a child or maybe a person with limited mental abilities, such as an intellectually disabled person or a senior with cognitive difficulties, or even potentially a pet. The person with this often basks in the attention. Aren't they a great, if it's on another person, the imposed on another, aren't they a great parent? Aren't they a great child? They sacrifice so much. They love the attention. They love to be viewed as self-sacrificing. They often like to be viewed as being able to outsmart the knowledgeable medical doctors. This condition can be obviously physically damaging or even potentially deadly. Can you think of any films on the topic? Hint, Bruce Willis, but it's an older film. Perhaps you saw Bruce Willis in the movie The Sixth Sense. One of the vignettes in it focused on this particular issue. So fictitious disorder is indeed a disorder that's in the somatoform and related disorders, or nowadays it's called somatic symptoms and related disorders. That was the previous DSM title. A disorder which is not in this family, but is usually discussed at the same point, is malingering. Malingering is not a mental illness. Malingering also involves faking symptoms or creating them, but for a monetary goal, such as you slip and fall and you feign injuries of a back nature to get compensation. You fake illness so that you can go on unemployment. So, although typically discussed in this area, in this chapter, again, this is not a DSM condition, and it's not a somatic symptom and related disorder condition. Let's consider a notorious example of one of our disorders. Depending on your age, you may or may not be familiar with Mary Beth Tinning. She was born very close to the college, Duanesburg. Her father, you can see where she worked from many of our classrooms at GE across the highway. She had, tragically, many children die from SIDS, one after the other, 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 and so on. And it was thought that she just carried dangerous genetics. This was long before genome analysis. Until her adopted child died of SIDS too, and that really caught the attention of the coroner. Bodies were exhumed, and it was found that she was a serial killer of her own children. She was convicted for killing one of the children, jailed in 1987, paroled fairly recently in 2018, and as of the time that this video was recorded, still alive with her husband, who stayed married to her. So see if you can determine what disorder she had. She liked to play the role of the doting mother, of the grieving mother, of the poor, pitiful mother. All the attention that she received after child, again, 8 children died. What disorder does this sound like? Think on that for a moment. If you're thinking Munchausen, fine, but remember Munchausen won't be found in the DSM. It's not a DSM term. So what would be the DSM term for it? Psychophysiological disorder, conversion disorder, which is now functional neurological symptom disorder, which term you don't need to know, illness anxiety disorder, somatoform disorder, fictitious disorder, malingering. It would be one of those. Think a moment. If you decide fictitious disorder, yes indeed, but here's the next question. What type of fictitious disorder? There's the standard one, just fictitious disorder, and then there's fictitious disorder focused on the other. It would be the fictitious disorder focused on the other. The term would be by proxy. So yes, she could clearly be diagnosed with fictitious disorder by proxy. Let's test our understanding of these basic concepts. So go ahead and match the term on the left with the corresponding definition on the right, and then answer the two other questions. And this is a great one to do over and over till you find it to be an easy task. This isn't all you would need to know for a test or a quiz, obviously, but you absolutely have to have this framework to add on the other information that should go with it. So go ahead, study a little bit, and see how you do. Okay, let's take a look. Illness anxiety disorder would correspond to our second definition, certainty of an illness with few or no symptoms at all. Next one, factitious disorder. The last one, psychologically created symptoms with no organic basis. The person believes that they are sick. Third one, conversion disorder. Sensory or motor symptoms with no organic basis. Malingering, maybe it's a mnemonic. M is for malingering, M is for money. They're faking it for money or other fiscal related advantages. Somatic symptom disorder, many symptoms. Unlike illness anxiety disorder, many symptoms with no organic cause. Next, which disorder is properly termed functional neurological symptom disorder? Hopefully you said conversion disorder. And the last point, disorders caused or made worse by stress are now termed, the third choice, psychophysiological disorders. If you did well, great. I would still review it for the test. If it gave you any trouble, just study a little bit more and keep doing it until it's easy. But don't forget to review it a day or two before the test. It'll be great help to you.